of small cell lung cancer were analyzed, and 75%, 3 out of 4 such patient of small cell lung cancer presented in an advanced stage, what we call it as extensive stage small cell lung cancer. So as such, the biology is bad, and on top of it, you have disease coming with an advanced stage. Sorry. So yeah, and this definitely makes the our task very difficult to treat such patients. So if you see the timeline of extensive stage small cell lung cancers, initially it started in 1985 with cisplatin and etoposide. So this was, and it is even today, it is one of the backbones of the treatment. In any treatment, even today, is incomplete without platinum and etoposide. So cis etoposide, and then after 14 years, that came carbo etoposide, that you can replace cisplatin with carboplatin, and then came carbo and irinotecan or cis irinotecan in 2006. So this has been the treatment options we have in the first line setting. And those who have relapsed, for such cases, we have taxanes, we have topotecan, we have gemcitabine, we have temozolomide, and then immunotherapy drugs. This is all for extensive stage. In limited stage, we all know we do go for localized stage. We do go for radiation therapy. There is some controversial role of PCI in today's era. But if you look at the extensive stage population, the median OS survival across more than 10 study, if you see, is less than 1 year, close to 9 months, 8 months, 9 months, 10 months, 12 months, 10 months, 10 months. So median survival has remained less than 1 year. And if you see, 1 year survival is in the range of 30-35% across 10 to 12 studies. So we do need better agents where you can improve our 1 year survival and 2 year survival as well. So we all know there have been two good molecules available in the last few years, and we all have used this immunotherapeutic agents. One is atezolizumab, and other is this durvalumab. So we have this IMPower 133 study where atezo was combined with cisplatin etoposide or carbo etoposide compared with placebo plus carbo etoposide, and then followed by a maintenance atezo or a maintenance placebo in the placebo arm. And this definitely, both the drugs did show wonderful results. Similarly, in Caspian study, it was a 3-arm study. It was durva, tremelimumab plus epilimumab, EP. Durva plus tremelimumab plus carboplatin or cisplatin plus etoposide versus only durvalumab plus EP versus only EP. So it was a 3-arm study. The primary endpoints were OS basically in both, but IMPower also had PFS as a co-primary endpoint. So if you see the results, both the trials had definitely shown better PFS and better OS. So 1 year PFS, if you see, was 12.6% versus 5.4% in the IMPower Atezo study, while it was 7.5% in the durvalumab Caspian study. Similarly, for OS, if you see, 1 year OS was 51% compared to 38, and for Durva study, it was 53% compared to 39%. So if you see, the hazard ratios were closely similar, 0.77 with Atezo and 0.78 with Durva, if you see the PFS. And if you see OS, the hazard ratios are also similar to, both the agents were quite similar to 0.70 and 0.73. So what I'm trying to say is both the drugs had almost similar responses in terms of, and similar benefits when added to the chemo backbone in terms of PFS as well as OS. So this is again the first line, platinum etoposide plus ICI. So you can see hazard ratio 0.7 versus 0.73, and delta, if you see the median OS, there was hardly 2 to 2.7 months. Atezo giving 2 months and Durva giving 2.7 months advantage. So there was a small benefit in terms of median overall survival if you look at in terms of months. And if you see in risk reduction based on the hazard ratio, you can see nearly 30%, 30% reduction in the risk of mortality while you are using this immune checkpoint inhibitors. Now came the game changer, that is Serplulimab, which is a PD-1 receptor inhibitor with a differentiated mode of action. How? It has two different advantages. One is it causes significant PD-1 internalization compared to Pambro and Nivo. If you still look at this graph on the left, so this is Serplulimab induced internalization of PD-1 receptors, while this is of Pambro and this is of Nivo. So this was study presented at 6 hour post incubation. PD1 endocytosis peaked while Pembro and Nivo mediated endocytosis PD1 was relatively weak, as you can see in this diagram. What is the another mechanism? This is a little complex, but I will try to simplify. So if you know that on a CD8 positive cytotoxic T cell, we have a PD1 receptor and there is a CD28 co-stimulatory receptor just besides it. So when there is an activation of PD1 or blockade of PD1, it forms a complex with this CD28 co-stimulatory receptor, which sends signals to the T cells through this PD1 associated SHP2 phosphatase, resulting in reduced co-stimulatory effect. So when Serplulimab is given, it blocks this CD28 cluster. So thereby the T cell activation is stimulated. Correct? So if you can see the anti-CD28 activity of Pembro, it is very high, but Serplu it is very less. So this is how it helps in having better PD1 internalization, and also it helps to reduce the inhibition of T cells and thereby increases the stimulation of the T cells, cytotoxic T cells, which have come to destroy the cancer cells. Again, how it differs from other PD1 inhibitors, correct? So now we'll talk about how it differs from the PDL1. So whenever we use PDL1 inhibitors, it only blocks PDL1 receptors, as you can see in this diagram. So there is something called PDL2, which are also present on the cancer cells. Although less in number, PDL1 are the majority, but this also acts as a binding agent with PD1. So when you block only this, PDL2 can bind with PD1 and inhibit the T cells. But when you are using a PD1 inhibitor, it makes PDL1 and L2 both unable to bind to PD1 and inhibit this. So there is better and prolonged activation of CD8 positive T cells. So this drug received an European Union approval for the first line treatment of extensive stage small cell lung cancer, and in India it received a DCGI approval in June 2025 for first line use in extensive stage small cell lung cancer. So this approval is based on the Astrum 005 study, which was a randomized double-blind placebo-controlled global phase 3 trial conducted in 114 sites across 6 countries like China, Georgia, Poland, Russia, Turkey, and Ukraine. So basically, in this, as we discussed, they were all extensive stage small cell lung cancer with no prior systemic therapy. Stratification predetermined was based on a PDL1 expression, brain metastasis, and age. Randomization 2:1 to Serplu plus carboito versus placebo plus carboito across 4 cycles, followed by maintenance Serplu until disease progression or toxicity, and the placebo arm was maintenance with placebo. So if you see the basic characteristics were quite matched. If you see 67%, 2/3 of the patient in both arms were Asian origin. Again, 75% of the patient were smokers and 20% were non-smoker in both the arm. PDL1, if you see the CPS score, almost half of the patient in both the arm had PDL1 CPS of 1 or more, and half had CPS of less than 1. Close to 12% patient in both the arms had brain metastasis, and quarter of them had liver metastasis in both the arms. So it was well balanced. So if we have this cross-trial comparison, which is not the best way to compare any molecule, but this is what we have. We don't have a head-to-head comparison of Serplulimab with any of the approved other drugs. So if you have this cross-trial comparison, so this trial had a maximum number of Asian patients. So out of 585, 68.5, that is 401 Asian patients were enrolled. While in this trial, out of 400, only 17%, that is 70 patients. And out of this, again, only hardly 80 patients, 14% of the patients were of Asian origin. So what about the results? So you can see the Kaplan-Meier curve separating close to around 4 months. Correct? From year onwards, they are getting separated close to around 4 months. So if you see hazard ratio, it is 0.63, much better than 0.70 and 0.73 with the previous molecules. And also the delta in median overall survival was 4.5 months compared to 2 and 2.5 months with the previous molecules. So if you see the 2025 ASCO, the end of study analysis, we have this overall survival in intention treat population. The 1 year survival rate were better with a delta of close to 17%. At 2 years, it was double in favor of Serplulimab arm, 16% with placebo versus 32% surviving at 2 years with addition of Serplulimab. At 3 years, it was more than double. 10% in placebo arm versus 25% in Serplulimab arm. And at 4 years, it was almost tripled 3 times. That is 7% in placebo arm versus 22% in the Serplulimab. This is because we all know those who have survived for 1 or 2 years, they are likely to survive for a longer period of time. Majority of them are going to the pull on for a much longer period of time. That is the benefit of immunotherapy we have all seen with most of the even older immunotherapy molecules. So there was a delta of 4.5 months absolute benefit in terms of median overall survival. 4-year survival was 22%. So 2 out of your 10 patients are going to live and be alive at 4 years. And proportion of patients alive at 4 years is 3 times the chemo that we discussed. And this is after a median follow-up of 42 months. That is nearly 3.5 years. Hazard ratio for OS was 0.60. So that is 40% reduction in the risk of death even after a longer follow-up. So if you see race, both Asian, non-Asian, liver mets, no liver mets. So most of the patient, if you see everything is on the left. So majority of the subsets were benefiting with use of Serplulimab. And what about, so what we would like to see is the CPS, even less than 1. So the major question sometimes people ask is about CPS less than 1. So again, they were also benefiting with a hazard ratio of 0.67. So this is a forest plot for subgroup analysis. So irrespective of the site of metastasis, irrespective of the CPS score, they were benefiting. What about the toxicity? They were like manageable. In the study, we all know the side effects were similar. Grade 3 or 4 treatment-related adverse events were 80% plus in both the arms. Treatment-related adverse events leading to discontinuation were 6% in Serplulimab compared to 5% in placebo, and deaths were 1.5% compared to 0.5. But we all know immunotherapy comes with its own challenges. We all have learned to manage all the itis related to immunotherapy and how to pick them up early and manage them and then re-challenge if possible. So this is again no different in terms of if you see the toxicity and immune-related adverse events. Very importantly, if it's mentioned here is 38%, which is likely double than this, and which is but obvious because chemo drugs are not going to have immune-related adverse events. So it was quite high. And this is what we commonly see, 1 out of 3 patients likely to have immune-related adverse event. So Serplulimab plus chemotherapy has achieved a 3-year OS rate of 24%, bringing extended survival benefits to this sort of patients who have poor prognosis at the time of diagnosis. So this is the cross comparison of all 3 trials. Caspian, the median OS was 13 months, it was 12 months, and here it is close to 16 months. And delta of 2 months with Atizo, 2.5 months with Durva. Here it is 4.7 months with Serplulimab. Hazard ratio again 0.61 with Serplulimab, 0.76 with Atizo, and 0.71 with Durva. 3-year survival rate again 24.5%. 24% patients alive at 3 years with Serplu, 16% with Atizo arm, and in 17% in the Durva trial. So again, this is a cross trial comparison. We cannot exactly compare, but this is the data we have. What about MCBS? That is magnitude of clinical benefit scale. So European Union, that is ESMO, it gives this MCBS grading to highlight those treatments which have substantial improvement in terms of survival or the quality of life of patients with cancer, and aims to distinguish this from trials which demonstrate some limited nominal marginal benefit in terms of survival. So it is based on this calculation. And based on that, Serplulimab has got a very high score of 4. So 1 to 5 is the scoring, and Serplulimab gives a score of 4. So 4 and 5 are having substantial, significant benefit. Beyond extensive stage small cell lung cancer. So what lies beyond this? So Serplulimab current indication and future development. So in China, it is also approved for extensive stage small cell. In addition to small cell lung cancer, it is also approved for squamous and non-squamous NSCLC. And also for esophageal squamous cell carcinoma who have a PD-L1 positive in first line. Phase 3 trials are going on. This is of Serplulimab plus chemo in first line esophageal extensive stage small cell lung cancer. It is a head-to-head trial versus Atizo, and enrollment has been completed. The study results will come out in at least another 2-3 years. Similarly, Serplulimab plus chemo in neoadjuvant and adjuvant setting for gastric cancers. It has Astrum 006. It has met the primary endpoint of EFS, and it has more than 3 times higher PAT-CR rates. So these are another phase 2 trials which are ongoing for NSCLC, mainly squamous, non-squamous, and some data where it is trial is going for HCC, where very interestingly they have targeted Serplulimab with Bevacizumab and HLX53, which is an anti-TIGIT molecule. So there is newer development in immunotherapy in terms of anti-lag and anti-TIGIT molecules, which try to reduce the resistant mechanisms to immune therapy. So coming to squamous NSCLC, that is Astrum 004. So this was the phase 3 study of Serplu plus chemo as first-line treatment of advanced squamous non-small cell lung cancer done in China. So again, stage 3B, C or 4 squamous NSCLC with no prior systemic therapy and no EGFR cross-1 mutations were included in the study. Stratification based on PD-L1 less than 1 to 50% versus more than 50% race. And this is stage 3B, C versus stage 4 were included. 2:1 randomization again, Serplu plus chemo versus placebo plus chemo every 3 weekly for 4 to 6 cycles for chemo up to, and then you continue maintenance with Serplu or placebo up to 2 years. Primary endpoint was PFS by independent radiological review committee, and secondary endpoints were OS, PFS, overall response rate, duration of response, safety, and exploration of biomarkers. So if you see the PFS graph is pretty much separating quite early within the first 3 months, within the 3 months, and it's staying separated. The median, the hazard ratio is 0.55, meaning there was 45% reduction in the risk of disease progression, and p-value was significant. Coming to overall survival, again here you are seeing the curves getting separated quite early within first 3 months, and a major separation you are seeing, and which is even maintained further down the line. And here the hazard ratio was 0.73. Very important to note is there was a 2-stage model adjustment of OS for trial crossover. So what happens is most of the trials crossover is allowed, where the patient in the placebo arm go on to receive Serplulimab drug. So basically this arm also had patients who have received Serplulimab on progression. So if you remove this patient, so 97 patients crossed over to Serplulimab arm. So if you remove this patient and analyze only those patients who have received placebo plus chemo and never received Serplulimab, so here the difference in hazard ratio is even better. That is 0.49. So there was reduction of 51% in mortality for somebody who has received Serplulimab versus somebody who has never received. So there was, so now a lot of trials I am seeing I am doing this. There is something called, I recently read, there was RPSFT, what they call, I forgot the full form. That is called RP, that is rank specific analysis of trials, where crossover, they remove the effect of crossover and try to analyze what if the crossover did not happen, what if somebody could not take the drug in second line. So here the hazard ratio is even stronger of 0.49. So even those patients who could not never take, compared to them, the magnitude of benefit was even much higher when you are using it in the first line. To conclude, with 31 months of follow-up, Serplu plus chemo, that is nab-paclitaxel, showed consistent benefit in terms of PFS, OS, response rate, and duration of response. We were statistically and clinically significant. So this has become one of the first-line treatment option in today's day for squamous NSCLC. What about non-squamous NSCLC? We have this Astrum 002 study. So final analysis from this was presented in ESMO Berlin recently in 2025. So this was the final analysis of first-line Serplulimab plus chemotherapy with or without HLX04 in advanced non-squamous non-small cell lung study. Again, a phase 3 randomized study. So what is HLX04? This is something like Bevacizumab. This is a VEGF inhibitor. I think it has a name like Habilix or Halinix, something sort of a name. This is basically a Chinese molecule which they use, but it is like a VEGF inhibitor, just like you can say Bevacizumab. So it was a randomized double-blind phase 3 study where this advanced stage 3B, C, and 4 patients who could not be treated with loco-regional therapy and who did not have EGFR cross-1 mutations were included. And it was a 1:1 randomization to 3 groups. The group 1 was Serplulimab plus this Bevacizumab. You can hear HLXs, you can say it as VEGF inhibitor, plus PEM carbo, followed by Serplu plus VEGF inhibitor plus pemetrexed as maintenance. Group B was Serplu plus chemo only, where VEGF inhibitor was replaced by its placebo. And group C, Serplu and this both were replaced by placebo. So basically it was only chemo arm. So this was chemo plus Serplu plus VEGF inhibition, and this was chemo plus Serplu, and this was only chemo arm, followed by the maintenance. And as you can see here, on progression in this arm, maintenance was there in all the 3 arms, and on progression they were allowed to switch to Serplulimab plus VEGF inhibitor. The primary endpoint was PFS, and the second endpoints were rest all OS, safety, PK studies, and all. The comparison was like this: Group A versus Group B, and Group B versus Group C. This two and this two. A versus B and B versus C. That was the primary method of comparison. If you see this Group B versus Group A, that is A versus B, definitely B was doing better. Correct? So Group A, median survival was 23 months, where all four drugs, three types of molecules were there: chemo, dual chemo drug, VEGF inhibitor, and Serplu. It had a median OS of 23 months, while this had a median this was of 27 months. The hazard ratio was also better, 0.66, while it was 1, and here p value was also significant. Correct. So again, they had a two-stage model where around 80 patients who crossed over to receive Serplu plus HLX were removed, and this hazard ratio even got stronger to 0.53 instead of 0.66. So this was for OS. This is for PFS. So again, for PFS, same thing. The PFS was almost identical. Hazard ratio was 1, and you can see the hazard ratio for Group B was better compared to the Group A. So even Serplu alone plus chemo was doing wonders. Addition of HLX-O4, that is VEGF inhibitor, was not helping much. So based on this, what we know is Serplulimab has a unique mechanism of action, including high PD-1 binding affinity, high PD-1 endocytosis, and preservation of CD28-mediated co-stimulation of T cell. Serplulimab has the highest ESMO MCBS score of 4 for extensive stage small cell lung cancer, indicated a substantial clinical benefit. So this represents the newer standard of care for first line ES-SCLC. And beyond this indication in China, there is very robust data for its use in squamous and non-squamous NSCLC. And there are a lot of trials which are ongoing, as we discussed, head-to-head trial with Atizo, phase 3 trial in localized stage with small cell lung cancer in addition to radiation therapy or as a consolidation. And even there is some trial, as we discussed, phase 2 trials going on in HCC. So this is what we know about Serplulimab. And what I can say is the inventor of Serplulimab have been fan of James Bond. Every trial is 002, 003, 005. And maybe soon they'll come up with a trial of 007. So that's all. Thank you. And over to you, Abhishek bhai.
Thank you. 007 नहीं आएगा, वो उनका ट्रेडमार्क है.
Huh?
007 cannot come. बहुत महंगा पड़ेगा. No, anybody has any queries for Chintan? And I think that was a comprehensive lecture for newer immunotherapy for lung cancer. Anybody has any personal experience?
No, Chindan, can I ask you one question?
Yes.
Whether it works in because its mechanism of action is little different than the conventional PDL1. So if the patient has progression on durvalumab, whether this drug will work in that patient or there are no studies on that?
So I'm not aware, honestly, of any such studies. But basically, of IO, what I have understood is just IO after IO. If I answer that question, I'm not sure about Serplulimab, Merck after Durva or Atizo. That I'm not sure. I have to look for such studies if they exist and they are there or not. But what I know about IO after IO is if the patient has progressed while IO is ongoing, then definitely another IO is not going to help. But if we have given IO and we have discontinued at 2 years because patient has very good response, and we are stopping at 2 years because patient is CR or near CR and the disease relapses, at that point of time, definitely IO will work again. Second condition is where patient has got a severe immune-related adverse event with one IO, and maybe you are re-challenging another IO after some time. That is what somewhere you can think of using IO after IO. But Serplu after immediately progression of Durva or Atizo or any other IO, I'm not sure. I have to look into it.
In a way, like if we use a patient have progression on nivolumab, we can add ipilimumab along with nivolumab.
Yes, yes.
Dual IO.
Dual CTLA inhibitor, yes, CTLA4, yes.
So anything like this, is there any data on this?
I'm not aware of, not honestly aware of any such data for Serplulimab especially.
Fine. Okay.
Chintan, you can stop sharing your slides.
Okay. I think I have stopped. Okay, sorry. Yeah.
So I'll share my screen.
I have stopped, yes.
Yes, sir.
Yeah.
So, can you see my slides?
No, sir. Uh, yes, sir. I
Yeah.
can.
Now.
Yes, yes.
Yes. Full screen kar do.
Yes. So the next topic is the new drug for lymphoma, which is Polatuzumab. I won't call it new now. It has been there for a while now, and we used it in a few patients with some good benefit. And we are going to discuss about Polatuzumab in diffuse large B-cell lymphoma. So obviously, this is a sponsored session by Roche. And let us start with the case. The case is a 61-year-old gentleman who has a history of presented with a left shoulder pain and swelling in the axillary region. And if we go to the physical examination, you can see there was left axillary lymphadenopathy, which was non-tender but palpable lymph nodes. PET CT told you that it was a stage 3 disease with possibly extra nodal involvement in the liver, but which was a query. So there was enlarged lymph nodes in the cervical axillary region. You had involvement in the left gastric region, and you had a focal involvement in the liver as well. So stage 3, possibly with extranodal disease. So that was one high risk. And obviously biopsy showed you that it was a lymphoma and a CD20 positive lymphoma. And more important than that, it was a diffuse large B-cell lymphoma with a non-GCB phenotype. MIB was 60%, but so indicating it was a high grade aggressive disease, stage 3 disease with some extranodal involvement as well. So there were quite a few reasons why the disease was bad. So this guy was treated with pola-R-CHP, and if I have to summarize the entire thing, the scans were obviously good. If you have to summarize, so July he presented with the complaints, and he had a diagnosis of non-GCB DLBCL double expressor type. Started on polar CHP. The interim response showed a partial response, and there was a significant reduction in the SUV in the nodes. And the final evaluation after 6 cycles told you that there was a CR. There was an excellent response to the polar CHP treatment regimen, and the patient is in CR as of today. So let us discuss about DLBCL and Polatuzumab. So we all know that DLBCL is a type of B cell lymphoma. More important than that is what is uh, important about DLBCL is we all are aware of the fact that it's a curable malignancy. But we all forget the fact that not everybody is cured. There are a set of patients who have a very aggressive disease, have a bad disease, difficult to cure disease, and they possibly land up into the second line with difficult options, I would say. Although there are better options than we had previously. You have the CAR T and you have the targeted therapies as well, but then still it's a challenging treatment post the second line, costly affair with a lot of complications and side effects though. So what is important is that the first chance is our best chance of cure, and we are quite aware of the fact that at least 50 to 60% do get cured, and there is a serious need to improve that figure of 60-65%, and that is where this drug comes into. So the journey of DLBCL, as I just told you, from screening to diagnosis. So RCHOP has always been the standard of care, first line treatment, and as the slide shows you, 60% would be cured. Rest is the challenge. So the rest of the 40% would again land up into second line, third line treatment, transplant, CAR T, possibly an endless journey. Few of them get cured, others keep relapsing. So the 60% chance, if there is a chance that you could improve it to, let's say, anywhere from 60 to 70, 75%, it still improves the patient's chances of cure, quality of life, and definitely the second line options are not easy. And so the first chance is always the best chance. So we haven't had anything. So that effort has always been there to improve our CHOP, and people have tried anything and everything. I'll show you the slide. From instead of the R, you went to Gazyva, we went to an R square, we went to R len, we went to R boti. We even used Gazyva with ibrutinib with R chop. I have used it in a patient, nothing. There was gemcitabine, there was R daipoch, which some people are still a fan of. That R daipoch does better in aggressive bad diseases. but a questionable suggestion. So all of this failed. Nothing has worked till date. And what is important is that Polatuzumab is the first drug after a lot of time which has at least showed you a progression-free survival. And definitely it is showing you improvement as far as the bad biology goes. There is where you need the efforts to be. So this is data from India where it has shown you that the 2-year PFS and OS is around 69 to 79%. Quite impressive. I think it's good. And we don't have the 5-year data from India, but then it should be around 50%. That is what I believe, because DLBCLs, at least out of 10, half of them do get cured, half of them do relapse. And this is one of the reasons. So clinically, if you have to judge a patient, this is the best way, that if you have a patient with a, as you do it on bedside, with the IPI score is low, has an obviously an early stage disease, has a GCB phenotype, you have the best chance of cure. On the contrary, if you have a high IPI, you have an elderly informed patient with comorbidities, you have the non-ABC phenotype, you are in trouble. That means there is a chance of relapse. The disease generally tends to be aggressive, extranodal, with a lot of spread everywhere. So there is a significant need, we all know, of improvement, especially in the bad phenotype, and there is where this drug has come, which is your Polatuzumab, which is a antibody against CD79B with a, it's an ADC with a targeted microtubule inhibitor, and it's an antibody drug conjugate together with the anti-CD20 rituximab and the chemo. It is now the standard of care, and this is the trial, the Polaris trial, which led to the approval, especially in the high IPA or the advanced stage settings. So what about the trial? Let us see. So this is your Polarix trial where there were two arms. Obviously, one arm had your Polatuzumab with rituximab with CHP, and other arm was your standard R-CHOP. About 6 cycles of both, followed by 2 cycles of rituximab maintenance. What is slightly different in this trial from the others would be that you had patients from 18 to 80 years of age. So you had a subset of patients who were elderly lymphomas, which is always a troublesome subset to treat. You are always worried about the side effects and what to treat and how to treat. But Pola RCHP was used in even patients beyond 70, and they had a manageable safety profile. Obviously, they were randomized in terms of the IPI, the high versus the low IPI, the bad versus the, or you can say the bulky versus the non-bulky disease. And assessment was in the terms of PFS, as well as they are still following up with the OS, which is showing a trend towards improvement. So with this is the 5-year PFS at 2 years and 5 years, and what you can see is the PFS at 2 years, that is 28.2 months. HR is 0.73. So roughly at least around more than 25% patients are still not have relapsed in progression-free survival, and at 5 years it is 0.77, making 23. So let's say about 23% of the patients have not progressed on to the second line treatment options. So that is what it tells you, that patients treated with Pola or CHP, 23% fewer patients required a subsequent line of treatment, hadn't relapsed. What about the OS? So the 5-year OS, you can see as the 5-year data is reached. So initial 2-year OS was 0.94, was not very significant. Even the 3-year update did not show you any significance, but gradually the 5-year update is telling you that there is a slight trend towards an overall survival. And what about the Asian cohort? Then the Asian cohort, there is a trend towards OS benefit with their extended 5-year overall survival. You can see the HR is 0.65. So compared to Arch of the Polar CHP, the 5-year OS is 84.6 compared to 77.7, HR being 0.65. So at least Asian subset is doing better. Asian does not mean Indian, but then the Asian subsets are doing better. One reason could be that clinically we generally tend to see that our patients come in a very advanced, in a bad stage. We have worse lymphomas than possibly the Western population. So, and that is where the drug also scores. The worse the disease, the better the chances that your drug is going to be a cost benefit ratio, because it is not a cheap drug to be using. So the 5-year PFS, what is important is, I've highlighted the red part. What is important is that you can see even with this nanostring tech, or so obviously we are in DLBCL also Solid tumors, we are fans of NGS. Unfortunately, in lymphoma, we haven't had that kind of technology, but then it has evolved and it's surely going to come in the near future. Already, the trials are there, the data is there, although we don't use it clinically. But once you have proven that your disease is bad, so what is that is what it's showing with the best of the technology. If you have proven that the disease is bad, that is where the best of the survival is. You can see the HR is 0.49, and the discussion is all about that. It's a molecularly heterogeneous disease. We know that because once we 20 years back, it was either lymphoma, it was a DLBCL or a non-DLBCL. Then it turned out to be GCB, non-GCB. Now you know there are subtypes. You even know the NGS will help you demarcate which is a good or which is a bad type of lymphoma, just like we know for an AML or we know for a solid tumors. And that is what the slide is telling you in the ABC phenotype. If we have to just segregate it by the today's classification as ABC and GCB, in the ABC subtype, the Pola CHP is scoring over your standard R-CHOP. And clinically also we know R-CHOP is becomes highly ineffective or it is less effective in a patient who has a bad disease, has an extensive disease, has an extranodal disease, has a bad phenotype. Your patients generally tend to relapse. And definitely you can see at 2 years, HR is 0.34, and that is going to the same slide is being the thing is being replicated again and again that if the bad disease is there, adding an ADC is helping you. Then the same is being shown here. And that is what basically we are trying to evaluate. That this is the Digi score as it is being written here. So it's a genetic signature telling you that the patient has a bad disease or it has a good disease. Just like in the case of any other malignancy, if the digital signature showed you that it's a bad disease, obviously adding a ADC helped. And that is what the trial proved, that adding a ADC definitely helped. Even the ABC, you could say it clinically or histopath wise, IHC wise as ABC, or you could do a digital signature and say that it's a bad disease, needs a better treatment. Again, DLBCLs with extranodal disease, adding a Polatuzumab definitely helped. HR was better. As I was telling you, elderly population, so 70 to 80, which is always the excluded population in a clinical trial. Most clinical trials would not take patients beyond 70 or 65. So PFS or tolerance, the responses were equal, were replicated and were good in patients who had ages beyond 70 also in a case of diffuse large B cell lymphoma. You can see the PFS, the HR, and in the OS, the HR is significantly better, 0.74 and 0.64 compared to your standard R-CHOP. And more important is the side effect profile, which was comparable to your standard R-CHOP. It was no worse than the standard R-CHOP regime. So common side effects of particular interest is neuropathy. Neuropathy is a challenge with the Polatuzumab, but it's quite manageable. I don't think it is a limiting toxicity. You have to manage it. Rest of the toxicities obviously are hematological, as would be the case in any hematological malignancy. You have the neutropenias and the thrombocytopenia, the infection side effects, but you can see in the R-CHOP arm, they are comparable to your Pola CHP arm. So there is a mild difference, but it's not very high. It's a manageable side effects and not significantly higher than your standard R-CHOP regime. So as we generally tend to follow in most of our clinical scenarios, the NCCN guidelines has recommended it definitely in the high IPI, the bad diseases, and even in early stage diseases, if the IPI is high or you have extranodal, extensive or a bad disease, Pola R-CHP is the standard of care. Obviously, pending your economic profile, because R-CHOP is quite inexpensive now considering the generics which are available in India. But Pola R-CHP, my clinical experience has been that in aggressive patients, bad diseases, definitely you should be explaining it, because there in the few patients which I have treated, they were ABCs, extensive diseases, bad profiles. Those patients have been doing well still as of today with the addition of Polatuzumab. Does not mean they wouldn't have done well with a R-CHOP, but our data tends to tell us the same, that a bad profile of a patient, he needs something better than R-CHOP. So POLARx is the first trial, if I have to summarize, in over 20 years to show a meaningful improvement in the benefit risk profile over R-CHOP. And this has been proved in a randomized phase 3 trial. Long-term follow-up analysis confirms an ongoing encouraging PFS benefit, and there is a positive trend in favor of the OS towards the POLA-R-CHP arm. The benefits hold even more importance in the setting that our patients have limited options in the second line arm. I think somebody's kindly is mute your iPhone. Somebody's phone is. Pola-R-CHP is a category 1 preferred regime as per NCCN and NICE guidelines. So most of the guidelines would tell you that Pola-R-CHP is the standard of care now, especially in high IPI diseases, which is bad diseases. And it has to be offered to a patient who has a bad disease. That is what I can conclude from the limited experience I had with Polatuzumab, as well as the data which the trial tends to provide us. With that, I would like to thank the sponsors. And if anybody has a question, I would be very happy to answer. So we finished well in advance. Rahul, anybody has a question? So everybody is very well read. So Dr. Richard has joined us? Yes, I think so. He's there.
Yeah, he has joined. Yeah.
Sorry to keep you waiting, Dr. Richard.
Not at all, not at all. I just joined a few minutes ago, and I love lymphoma as well. I mean, I don't see as much, but I always like to try to keep up on all areas of oncology.
Thank you. So should we continue?
I guess I have a question for you real quick. Do you guys, since I don't know if a lot of people here use this dose intense CHOP or EPOC, right? Dose modified EPOC. And from what I understand, there's no strong data to do that. Is that something you guys do there, or is it a certain subtype that benefits?
So one subtype where there is no controversy is the primary mediastinal lymphoma, where we definitely use it. Also in our elderly Burkitt's, I think it is a good regime for an elderly Burkitt's who is not able to tolerate your hypercvad. For the others, many have an opinion that R-the-epoch is better than a conventional R-CHOP. Although we have not been able to prove it on paper, that is what I recollect. So still R-CHOP remains the standard of care, or a Pola-R-CHP. But the two subsets which are definitely benefiting is your PMBCL and your elderly Burkitt's. So there we can definitely use it. And we are using it. So you can
great.
R-the-epoch, many a times we do use it in such settings also, high-grade B-cell lymphomas or bad diseases, because it tends to be a cheaper option than a Pola-R-CHP for a country like India. So I think they are not wrong if they try something different, considering the cost of Polatuzumab is not affordable to most Indians.
Okay.
Anybody else would like to add anything? All right. So I think we can continue. Instead of keeping everybody waiting, let me introduce Dr. Richard Finn. You've already seen him. He's already joined us before time. So Dr. Richard Finn is a professor of medicine for hematology oncology, as most of us are practicing hemat and onco at the UCLA David Geffen School of Medicine. And he's a key expert or an opinion leader in liver and breast cancer. I have been told that he is a pioneer in HCC, as he has been the chief investigator for your IMBRAVE 150 trial. He is the director at Signal Transduction Therapeutics Program at the UCLA Johnson Comprehensive Cancer Center, as well as a physician at the UCLA Liver Cancer Center, past president of the International Liver Cancer Association. And as I told you, he's a renowned expert in the field of hepatocellular carcinoma, molecular targeted and biomarker driven oncology, and that is where oncology is going, biomarker driven. Although lymphoma we are lagging behind, but then I think biomarker molecularly targets oncology, precision medicine as we like to call it, is the future of oncology. And without delay, I would like Dr. Richard Finn to please go ahead with his presentation on HCC.
Thank you very much for that very nice introduction. Thank you very much to the Roche team for having me. I was in India over the summer, I think, and had a very nice visit, meeting many of you in person, or maybe not the people on the phone, but your colleagues, and hope to get back. India is a very large country, a lot of area to cover in a few days, but thank you for joining, and especially at the end of the year when things tend to get a little busy. But I hope everybody's getting ready for a slowdown. Let me just adjust the picture here. Okay, here we go. So these are my disclosures. I consult for many companies, not just Genentech, Roche. So the BCLC has been the backbone for how we approach liver cancer. And when I say the backbone, at least how we triage patients. And I think it's important to think of it as a paradigm and a basis for clinical trials. Not to belabor the point, but there's some patients who are just very sick who are going to die of liver disease unless they get a liver transplant. Those are these late stage D patients, or if they're not transplant candidates, then supportive care and hospice is probably appropriate. Then on the other side of the spectrum, there are those patients who have earlier stage disease and are potentially curable with resection or local treatment such as ablation or chemoembolization. Now, the majority of patients I think I see in my practice are unresectable. And unresectable is a large group. It's not just intermediate and advanced, but both of them. You could have patients who are unresectable physiologically or oncologically. And for the backbone, for these patients, it's been chemoembolization for many years. However, we now appreciate that there are different groups within that intermediate, and maybe there are some that are even better suited for systemic treatment. And these are these diffuse, bilobar, infiltrative, just very large tumor burdens in the liver, which local treatment won't suffice of itself. Then there's the patients who have advanced disease, who are appropriate candidates for medical treatment. And this includes patients with extrahepatic spread, metastatic disease, or those who have vascular invasion, macrovascular invasion. And then keep in mind that for patients who get local treatments and do not get cured with a transplant or die of some other illness, eventually they will become taste refractory. And at that point, they also stage migrate and would be appropriate for medical treatment. And we'll go through the detail of the medical treatments in the next slides. For thoroughness, I just want to present that the BCLC was updated in the last few weeks. There is a proof online in Journal of Hepatology, but not really much has changed. If you look at the categories, the staging, nothing has changed. The diagram is pretty much the similar. ESMO guidelines also support this concept that there's patients who are intermediate Barcelona B who are not suitable for local regional therapy and should get systemic treatment. And then, for systemic treatment, there's this group, the BCLC B or Cs that we're considering for medical treatment, intermediate or advanced. And, they break it down to patients who are not suitable for immune checkpoints, and obviously the TKIs are appropriate. But the preferred agent, and I know you were talking before about the ADC, and finances come into play, of course, but ultimately, at least the guidelines are based on efficacy. And that's why the first question is, are you suitable for an ICI? Because all of these ICI doublets have been shown to be better than TKI. And then at progression, it's a little bit more speculative of what's the best thing to do. And we could talk about that during the discussion, maybe. So we have many phase 3 studies that have been done globally that have shown a real evolution in the treatment of liver cancer. I was around in the pre-SHARP days, When we were giving doxorubicin, we were giving tamoxifen, we were giving all sorts of things that had no proven activity, but it made us feel good to do something. And sorafenib was evaluated in a double-blind, placebo-controlled study, improved survival, hazard ratio 0.69. In the treatment group, survival was about 11 months. It improved time to progression, but it did that without an objective response. 2% ORR, mostly driven by stable disease, which made many of us appreciate that we had level 1 evidence, but certainly interventional radiology, an important player in this field, and surgeons didn't feel very strongly that this was an active drug. And I'd say IR continued to fill a void, probably doing LRT on patients who were not going to benefit. Yeah, we just need people to mute. Please mute. Thank you. So then we had a long drought of 9 years until we had the REFLECT study where lenvatinib, a potent TKI, was evaluated. And we had a hazard ratio of 0.92, which was non-inferior for OS. OS now with len was about 13 and a half months, improved PFS, and for the first time we had an objective response rate of 19%. Quite significant progress for that time. Now, with some bias, I'll say the biggest breakthrough was the approval of atezobev back in 2020 in the US. And this was an open label study of atezobev versus sorafenib. Yeah, can someone mute these people? Is there a host? Yeah, thanks. Sorry. So IMBRAVE 150 looked at atezobev versus sorafenib, was open label, and improved OS for the first time versus TKI. Median survival was over 19 months. Improved PFS, and most striking, an objective response rate of 30%. Then we had Himalaya looking at durvalumab. So this was a single dose of CTLA-4 inhibitor with a PD-L1 inhibitor. Again, open label. Improved overall survival. Median survival was only 16 months, but still improved it. And this had a single agent durva arm, which did not. So clearly tremi improved survival where durva did not. However, no effect on PFS and a 20% objective response rate. The CARE study, I present only conceptually. It's not approved in the US or Europe. And conceptually meaning it used a TKI in combination with PD-L1. And again, met its endpoints for OS, PFS, and ORR. And then this year in the US, and I think it was presented last year, but published this year, was Checkmate 9DW, which was len or sorafenib versus ipi-nivo, a very potent CTLA-4 PD-1 combination approved in many diseases. And this improved overall survival with a median survival of 24 months. Again, no effect on PFS and an objective response rate of 36%. So it's important, though, all of these 4 doublets improved overall survival versus TKI. But there is a little bit of apples and oranges comparison here because not all of them included high-risk patients, right? The highest risk patients are those who have VP4 or main portal vein invasion, or VP4 is not only main portal vein, but intrahepatic main branch. So none of these included main portal vein invasion, which is a very advanced feature, bad prognosis. VP4 was included in Himalaya, but not extrahepatic venous invasion. Checkmate 90W didn't include either, whereas the CARE study, IMBRAVE 150 did. So why do I mention that? Well, having this high-risk group of patients is very prognostic, right? So, people say, well, Checkmate 90W had a survival of 24 months. Well, again, that's a survival of 24 months in a low-risk group of patients, and we'll come back to that. Similarly, Himalaya had a lower-risk group of patients and only had a survival of 16 months. And certainly these prognostic factors can also affect objective response rate. So the development of atezobev did not come out of a vacuum. We actually had a long-time interest in bevacizumab, dating back many years, where we published this this laboratory study, an in vivo study, using a human liver cancer growing in a mouse, and showed that bevacizumab delayed the increase in AFP and actually helped the mice live longer. And as you know, bevacizumab is a monoclonal antibody to VEGF protein. And at the time, actually, there was the single agent study done with bevacizumab, which actually showed a few responses, not dramatic, like any other anti-angiogenic agent in liver cancer. But survival was about 10, 11 months, median survival. And, they had some toxicities here. The patients were not selected very carefully, so they had some bleeding. And at the same time, Bev was being developed in some other diseases and never really moved much further in HCC. However, it came back as we had a better understanding of the role of VEGF in the immune system and microenvironment. If we fast forward now from 2008, 2009, from our lab work and that small study, fast forward 10 years, and we start to understand that PD-1, PD-L1 inhibitors are important in cancer medicine and specifically liver cancer, and that bevacizumab does more than just starve a tumor of blood, right? That was part of the initial hypotheses, and improve the vasculature for chemotherapy delivery, which is the rationale for combining it in lung cancer and colon cancer, and ovarian cancer. But here we've seen that bevacizumab, by normalizing the vasculature, can increase T cell infiltration, decrease immunosuppressive T cell which blocks, the negative feedback and can improve T cell activation. So here you have the key efficacies data from the randomized study of atezobev versus sorafenib. Hazard ratio was 0.66 with a median OS of 19 months, ORR of 30%, and a PFS of about 7 months. Now, this study was stopped at its first interim analysis because the curve separated and remained separated. So the longest follow-up we have is 18 months. And I want to just point out, at 18 months, we have a survival of 52% in the atezobev arm, and then it's censored. And importantly, PFS, the curves separate very fast. So there's a group of patients, about 25% of them, who progress very fast, and that is attenuated with the use of atezobev. As similarly, the survival curves separate very fast. And this probably represents the fact that we have this high-risk population of patients who progress quickly. Now, I had mentioned that the other studies did not have all these high-risk patients. And there's two things to learn from this analysis where we looked at the high risk versus the low risk. And this is retrospectively from IMBRAVE 150. If we first look at the high-risk patients, these patients do very bad. With sorafenib, OS is 5.5 months, and with atezobev, 7.5 months. So they still get a benefit from atezobev, hazard ratio 0.62, similar to the overall population, but it's still an unmet need. Then there's these non-high-risk patients, the ones that, for example, were included in Checkmate 9DW, where they had a survival of 23.5 months, 23.7 months. Well, here you can see that the natural history of those patients is different. With atezobev, 23 months, 22.8 months, very similar to Checkmate 9DW when you start looking at these low-risk patients. Also, if you look at this compared to the Himalaya population, where it was a survival of about 16.5 months, here we have over 22 months. Again, a hazard ratio of 0.68, and the curves separate early. So the other thing I would like to comment on is this myth that checkpoint inhibitors don't work in non-viral liver disease, especially NASH or MASH or MASL. Obviously fatty liver is a big problem globally. And this study included all patients with liver cancer, regardless of etiology. And here we're looking at the survival of the subgroups. Now, the hazard ratio for this non-viral, which includes MASH, alcohol, and other causes, the hazard ratio is 1.0, right? So, people say, well, look, doesn't work in this subgroup? Well, you need to look a little more carefully. You can't just look at the headlines and not look at the data a little more carefully. So you can see here there were 150 patients in this arm, and these patients were randomized 2-to-1. So there were 100 patients with atezo-bev, 50 patients with sorafenib. If you look at the survival data with atezo-bev, you can see 17 months is very similar to the hepatitis B cohort of 19 months. Hepatitis C here did pretty well with 25 months. But again, that's a small group of patients. If it's 108, that's like 66 versus 33 or something like that. However, what makes this hazard ratio 1 is not an underperformance of atezo-bev, it's an overperformance of sorafenib. Here you see sorafenib had a survival of 18 months as compared to the 12 months seen in the other two groups. And again, I suspect this 18 months is an artifact that it's a small group of patients, 50 patients in this arm. You know, there's never been a study that has shown atezo-bev or sorafenib has a survival of 18 months in liver cancer. Also, to support this concept that it works regardless of etiology, let's look at objective response rate, which I think is one of the main indicators of activity with, drugs, immune checkpoint inhibitors in liver cancer. The excitement of these drugs is that they not only improve survival, but we get significant objective responses. You can see the objective response is regardless of etiology, 27%, 30%, 32%. And along that line of response is prognostic, right? We know that if you have a response to a checkpoint inhibitor, single agent or doublet, for example, but here's data with atezo-bev, your survival curve is very good. And here, looking out over a year and a half, the curve is pretty flat, and then there's a lot of censoring. If you have stable disease by RECIST 1.1, still your survival is pretty good, 17 months. But if you progress on frontline atezo-bev, you're not going to do well. 7 months median overall survival. So very important question about how we manage these patients in second line. How do we salvage this poor prognosis? Personally, in the US, we have some liberty to use drugs in different ways. And I've seen many of these patients respond to like ipi-nivo in the second line, which suggests that, CTLA-4 is different than VEGF. I think we know that. But it's an interesting question to be tested prospectively. But the point is we want to achieve a response. And clearly in this population and data set, atezo-bev has one of the highest objective response rates. And that objective response rate isn't limited to a certain tumor burden. This study done by Riyad Salem and Ricardo Lencioni, interventional radiologists, looked at quite some detail of the tumor burden in patients with HCC on IMBRAVE 150. And they looked at tumor size, whether or not they had prior chemoembolization, etc. And they showed that regardless of tumor size, whether it was small tumor burden or large tumor burden, patients had significant objective response benefit. You can see here some examples from the study of a patient, and you can see dramatic responses, not only by RECIST, but also by modified RECIST, where it looks like a complete response. So obviously all that needs to be weighed against toxicity. We know that atezolizumab, well, first of all, these are monoclonal antibodies, right? So all the toxicity is related to the target. It's not off-target type of toxicities we see with TKIs. So, with sorafenib, we see hypertension, proteinuria, fatigue, etc. Diarrhea is a big problem, hand-foot skin reaction. Atezolizumab is a PD-L1 antibody, so the toxicities are pretty much immune-related, and we'll go through that. But most commonly, we see itching and thyroid disorders. Important to note, the need for steroids with atezo-bev to manage an immune-related adverse event is only about 10-12%. The most common toxicities we see, though, are related to the BEV. And again, a monoclonal antibody to VEGF. So what we see is hypertension, proteinuria, some fatigue. We don't see a lot of GI toxicity. We don't see any hand-foot skin reaction, alopecia, asthenia. So clearly, looking at this profile, we see that atezo-bev is more favorable than sorafenib, and quality of life is improved. Now, going into a little more detail, as far as high-grade events, you can see that all grade adverse events were very similar. Treatment-related adverse events were higher with sorafenib. The grade 3-4 treatment-related adverse events were higher with sorafenib. SAEs were very similar, significant adverse events. And keep in mind, patients with atezo-bev were on the drug longer. So usually when patients are on a drug longer, there's more time for them to develop an adverse event. And even though that's the case, we see that these are more favorable with atezo-bev. And treatment-related grade 5 events, so death events, 2% versus less than 1%, fairly similar with a sorafenib, but higher. And we'll come back to that, 2%. And the amount of patients who have to stop both atezo and bev, 7%. Several patients on study could drop the atezo or more commonly the bev and then continue. Now, obviously, there's a concern about bleeding with bevacizumab. And all patients on the study had to have an upper endoscopy before coming on within 6 months. And you can see here about a quarter of patients in both arms had known varices at baseline. And a subset of them had them treated at baseline and then came on study. Having varices is not a contraindication to atezo-bev. Having them treated is not a contraindication to atezo-bev. The contraindication as far as bleeding are those that are very large tumor, very large varices that could bleed, or recent bleeding. But just having varices or varices that were treated, those patients should be treated with atezo-bev because it's very active. And you can see if you look at this high, over 70% of patients in each arm had macrovascular invasion or extrahepatic spread, so a high-risk group of patients. Now, looking at bleeding events specifically, you can see all grade bleeding events were very similar. 25, all grade 3-4 bleeding events, I should say. High grade bleeding events were very similar. 6.4 versus 5.8. A little higher with atezo-bev. All grade events were higher with atezo-bev, 25 versus 17%. But again, most of this is driven by epistaxis, hematuria, gingival bleeding, low grade bleeding. But we're going to look a little closer at upper GI bleeding. If you look at grade 3-4 upper GI events, we have, and they're coded different ways in the database. We have esophageal varices, 1.8, GI hemorrhage, 1.2, so that's 3%, right? Grade 3-4. And then there's a code here, upper GI, so 3.6% had some sort of grade 3-4 upper GI bleeding. Well, if you look at sorafenib, you have 0.6 and 1.9. That's 2.5% plus 1.3% upper GI. It comes out to 3.8%. So very similar frequency of high-grade bleeding events, regardless of how they're coded, between sorafenib and atezo-bev. And here, looking a little more closely, including grade 5, so death events. There were no death events with sorafenib. Here, there were 4 of them out of 330 patients, so 1.2%. And we know that the patients who have these high-grade events, both grade 5 and grade 3-4, many of them have the high-risk features, right? We know that the patients who had these high-grade bleeding events, GI hemorrhage, there were 2 of them with atezo-bev. These are the patients who had, main portal vein invasion, a risk factor for bleeding. And main portal vein invasion was not included in those patients in the other phase 3 studies. So even though they're high risk, there's still a benefit, and the risk of bleeding, is relatively low. Or bleeding death, I should say. And then we tried to define when this bleeding occurs, right? So, keep in mind, bevacizumab is not heparin, right? It doesn't cause a coagulopathy. It's a biological effect on the the blood vessels. And what we see here is that the median time to bleeding, any grade bleeding or even high grade bleeding, regardless of patients having varices or not, is in the range of 6, 7, 8 months, right? It's not something that happens very quickly, uh, with a patient. And now we have a lot of real world evidence that supports the efficacy of atezobev. This multi-center study from Europe demonstrated that, in Child-Pugh A patients, they had a survival of 17 months, Child-Pugh B, 7 months, PFS was about 7.5 months. Bleeding events were similar to what we saw in the phase 3 study, grade 3, 6% here. And that bleeding, was regardless of whether they had varices or not, or regardless of Child-Pugh status. And they concluded in this patient that there's a population of patients that suffer adverse events with atezobev, and really these are those with VP4, tumor thrombus in the main trunk or contralateral portal vein, and that there's no correlation between the presence of varices on EGD and bleeding events, and concluded that if identified and adequately treated, the presence of varices is not associated with risk of GI bleeding, thus making the delivery of atezobev a safe option in this population. We also have this study looking at efficacy from the AB-REAL study, again, a global observational study where they confirmed an objective response rate of 30%, bleeding events 75% treatment related, but most common hypertension, proteinuria. You can see treatment related AEs were 25%, but bleeding events 8%, very similar to what we've seen in other real world and phase 3 study. Now, just presented recently at ESMO a few weeks ago was this very large study from France of over 4,500 patients. Over almost 900 of them received atezobev and analyzed 800 of them. And you can see here the baseline characteristics, not that surprising for patients from Europe. A lot of alcohol disease in this population, and less so of just virus or fatty liver, but many of them overlapped with alcohol as well. Most of them were Child-Pugh A. You can see here 57% of them had varices, 26% of them had large varices and still came on study, and many had vascular invasion. So here they have long-term follow-up. So 42 months, PFS 5.8 months, median survival 23 months. So very comparable to the phase 3 data, if anything, a little better median OS. But again, this is not a randomized study. Here looking at BCLC stage. So intermediate versus advanced. And we know intermediate patients always do better because it's prognostic. But needless to say, you see the OS for these groups is, as expected based on phase 3 data. And here by Child-Pugh score. And again, Child-Pugh score is prognostic. And that's why Child-Pugh A patients do better than Child-Pugh B. And you can see here, median OS for those patients who are Child-Pugh A was 27%. And, Child-Pugh B is an unmet need. Patients with Child-Pugh B disease are not enrolled in phase 3 clinical studies just because they die of liver disease, not necessarily of cancer. But there are patients who probably have a high tumor burden. And in this study from Japan, they showed prospectively in a small cohort that atezobev was well tolerated and maintained similar anti-tumor activity in Child-Pugh B patients. And you can see here an objective response rate of 40% by RECIST, quite high, but again, a small population. And median survival OS here was 16 months in Child-Pugh B, which is not too bad compared to patients with Child-Pugh, where it was 19 months in a large phase 3 study. So I just want to show some recent data also from ESMO. And this was a phase 3 study trying to improve on atezo-bev, really the first one since atezo-bev's approval. And it was atezo-bev versus atezo-bev and the TIGIT antibody tiragolumab. And this was based on an earlier study we did that suggested that perhaps tiragolumab, another checkpoint inhibitor, TIGIT, it blocks TIGIT, a checkpoint inhibitor, that added to atezo-bev might be better. And this was a global study, and it was placebo-controlled and double-blinded. Keep in mind, all of the IO doublet studies we've done to date have been open label because half the study is getting TKI. And we know when we go to blinded studies that are placebo-controlled, that's the highest level of proof for the activity of a regimen. So this was a negative study. Adding tira did not improve on atezo-bev, but the bar was very high with atezo-bev already. Still disappointing, but if you look at the PFS, it was 8 months and over 8 months in both arms. Very comparable to the PFS we saw in IMBRAVE 150, where it was about 7 months in that open label study. Here you have objective response rates. Again, between 26 and 30%, depending on the arm. Very comparable to the objective response rate we saw in IMBRAVE 150. And again, this was double-blind, placebo-controlled. And the toxicity was very similar as well. You can see here treatment-related grade 3-4 events. And here, concentrating on atezo-bev, because we do know that tira adds more adverse events, specifically itching and pruritus and rash. But needless to say, the grade 5 events with atezo-bev here was only 2%. And adverse events of special interest with the checkpoint inhibitor, you can see here 13% needed steroids with atezo-bev. And again, for bev, which would be mostly hypertension, proteinuria, the adverse events were very similar to what we saw in other studies. So I'm going to turn now to the competitive landscape where we have other options. Here from Himalaya, single dose of high-dose tremelimumab with durvalumab. You can see here the curves separate later, right? The survival curves overlap, and then only separate, after this 10-month range, 9-month range. Hazard ratio of 0.78 and median survival of 16.4 months. So it takes longer to see a separation, and the median in a lower risk population is not as high. There was no effect on PFS. So what does that mean? Well, that means half the patients progress radiographically or by survival in under 4 months. Whoops, sorry. And here you see objective response. With T300D, 20%. With Durva, it was 17%, and sorafenib, 5%. So really not a large effect on objective response with the addition of tremelimumab. But needless to say, it is higher than TKI, and the doublet improves survival, whereas single agent Durva does not. And here you see the adverse events. And keep in mind, this is a dual checkpoint inhibitor, so most of the adverse events, or I guess nearly all of them, are mediated by the immune system. And the death rate, treatment-related death rate, is 2%. That's exactly the death rate we saw with atezo-bev. So I hear a lot of noise about the danger of atezo-bev, but certainly it has toxicity, but it's toxicity that is really no more toxic than what we see with Himalaya, especially when we look at deaths. There is a higher need for steroids. Here you see the patients who got the doublet who needed steroids, it was 20%. And you can see here the immune-related adverse events, like other diseases, liver enzymes, GI toxicity, rash. But single-agent Durva those requiring high-dose steroids, only 9%. So when we add an additional ICI to any regimen, we increase the adverse events. We saw that with tiragolumab, and we see that, with CTLA-4. Now, there's been a lot of discussion about the long-term benefit with Himalaya because the study was not stopped at an interim analysis. It went to a longer analysis, so they have longer follow-up. But I want to point out here a few things. One, at 18 months, the survival with durvalumab is 49%. It's exactly the same of what we saw with atezo-bev, where it was about 50%, 52%. So, that's very interesting. And then the long-term follow-up is 20% survival. Very impressive to be able to say our patients with advanced liver cancer have a 20% chance of living 5 years. And that comes from, phase 3 data. And I'm going to come back to these numbers. So lastly, Checkmate 9DW looked at Nivo, Ipi versus Len or sorafenib. It's the only study that really compared to Len and had no main portal vein invasion. And here's the baseline characteristics, a global study. They also had 27% of patients who were intermediate or less. Keep in mind, as we showed before, intermediate patients have a better survival. In IMBRAVE 150, this was about 15%. And here you see an improvement in median survival. Hazard ratio is 0.79. This study reported the longest survival with a doublet, 24 months. But look at lenvatinib and sorafenib. Their survival was 20 months. Keep in mind, the initial Len data survival was 13 and a half months. So clearly the natural history of liver cancer has changed. And 20 months median survival is actually better than the 16 months we saw with durvalumab. What's odd about this curve is that you see for the first year, patients are doing better with TKI, that there's more deaths with Nivo-Ipi than with sorafenib. And presumably that could be related to toxicity. And then the curves separate and remain separated. And at 3 years, we have 38% survival. At 18 months, if you go up the curve, you'll see 18-month survival is about 58%, very similar to the other studies. Now, the objective response rate here was quite high, 36%. These happen quickly and are very durable. PFS, you can see if you look at the first part of the curve, actually the patients with Nivo-Ipi are progressing faster, right? There's more patients who progress at that early part of the curve, but then, like we saw with the survival curve, things flip. And median survival is very similar in both arms, 9 months. Treatment-related adverse events here are really related to the immune effects. Certainly, it appears to be better tolerated than lensorafenib. You can again see hypertension, diarrhea, hand-foot syndrome. We do see pruritus, hypothyroidism, liver enzyme increases. But the treatment-related death rate here is 4%. That's higher than the 2% that we saw with atezo-bev or durvalumab. And the need for steroids with this regimen, we're up to 29% for patients who need steroids for an immune-related adverse event, compared to 20% with Ipi-Nivo and 10-12% with atezo-bev. And I just want to come back to this long-term follow-up issue, because both these studies have long-term follow-up. We also have long-term follow-up from LEAP-002, which was a negative study. This was Len-Pembro versus Len. And you can see here the median survival in this double-blind placebo-controlled study. Len, again, had a survival of 19 months, very similar to Checkmate 9DW. The combination, 20 months. The medians barely separated here, right? However, if you look at the long-term follow-up at 48 months, 23% of patients are alive with Len-Pembro. And what this tells me is that regardless of the doublet, there's a group of patients who have long-term follow-up or long-term survival, and it's probably about 20%. At 48 months, it's 23%. We still have a lot of censoring, but you can anticipate the slope of this curve is getting very flat. So, we need to evaluate studies based on their primary endpoints, not on their secondary endpoints or experimental endpoints. And by that, you can see here that this is a negative study. I'm not going to say this was a positive study, but still, it's very interesting to note that 1 out of 5 patients have long-term survival. So I'm going to close real quick with intermediate disease. I know we're running a little late, but we have time for discussion. So intermediate disease is heterogeneous. You can see in this figure, there's the well-encapsulated type, then there's large confluent or infiltrative tumors. And we characterize these. There's been ways to subsegment them based on the number of tumors, the size of the tumors. And it's been hypothesized that those patients with larger tumors are probably better served with medical treatment than local regional treatment, like TACE. And we can see in the IMBRAVE 150, when we look at the Barcelona B intermediate patients, they do better than sorafenib, and they do better than the general population in the study, with a survival of over 2 years, PFS of over a year, and an objective response rate of 44%. That's very high. But again, it's in an intermediate group of patients. Now, there's been several studies that have looked at these combinations of systemic treatment and TACE. Emerald looked at durvalumab and Bev, very similar to atezo-bev, and showed an improvement in PFS of hazard ratio 0.77 and 7-month delta in PFS. Objective response rate with durva, Bev, and TACE was 44%. That 44% actually is very similar to the 44% I just mentioned with atezo-bev alone in intermediate disease. Similarly, Len-Pembro had a positive study, LEAP-012, an improvement in PFS, hazard ratio 0.66, improvement from 10 to 15 months. The curves separate quite early. Here, again, an objective response by RECIST of 47%, very similar to the 44% we saw with atezo-bev alone. Now, the Talent TACE study was presented recently at ESMO GI earlier this year, and this looked at atezo-bev versus TACE. And interestingly, this study concentrated only on those patients who had larger tumors, so greater than 6, sum of tumor size and diameter, tumor number and diameter. And the primary endpoint was TACE PFS and overall survival. TACE PFS is a composite endpoint that looks at not only death, but also untreatable progression. So when patients are failing TACE, and it's defined here, and this study mostly was done in China. But again, a positive study improving PFS from 7 to 11 months with the addition of atezo-bev to TACE in this high-risk population. Here using version 1.1, which is the more conventional way to assess PFS, still the same result in improvement with atezo-bev added to TACE for these larger liver-confined tumors. Overall survival is a little immature at this time, but it's very interesting to note that even in the control arm with intermediate disease, patients are living 3 years now, quite a long time for intermediate disease. And the objective response using RECIST criteria, which is somewhat similar to mRECIST, very high, 80%, but the conventional ORR, conventional RECIST, 49%. Very similar to all the other studies, right? We're all in this 45, 49% range. So in conclusion, IO doublets are the standard of care in advanced liver cancer. All of them have level 1 evidence that they improve overall survival versus TKI. Atezo-bev is the only one that consistently improved OS, PFS, and ORR, including this high-risk group of patients. We now have the safety and tolerability confirmed in 2 phase 3 studies that have shown very similar results, one of them double-blind, placebo-controlled. We have a lot of real-world evidence. And while bleeding occurs with atezo-bev, high-grade bleeding is uncommon, and the risk-benefit, I think, is quite favorable. So I want to acknowledge all my colleagues at UCLA. I worked with excellent hepatologists and IR. Several of my colleagues, you can see by their last name, come from India. So we have an excellent collaborative group that has really been very successful, and my success is really, uh, uh, you know, a reflection of the hard work of many of these people. So thank you very much for having me, and I think we now have time for discussion.
Thank you, Dr. Richard. It was an excellent and a very extensive presentation about the queries regarding atezolizumab that most of us have when we are using this regime. I think we can take the questions in the panel discussion. Dr. Richard has some time. He's going to be there, right?
Yes, I think we
So
have
I
some
think
time.
I'll invite Dr. Parikh. He is a hepatologist and liver transplant physician at Ahmedabad Apollo Hospital and its own clinic. And I would like him to please invite his panelists and start the panel discussion. And I think the panel discussion, we can ask the questions. Our panelists also will have some queries, and including other people who have any queries, we can ask Dr. Richard during the panel discussion only. Dr. Patik?
Yes, thank
I would
you.
request all the panelists to keep their videos on so that we can see all of them while they are discussing.
Uh, so I think thank you for inviting me, and Dr. Payne has answered most of the questions that we are going to discuss, and we are looking at the perspective from our practice from India, and all the practitioners from India would be giving their perspectives about how they feel about the disease management. So to start off, I think the BCLC 2025 is out, and they have incorporated the complexity, uncertainty, subjectivity, and emotion as a part of the management of BCLC 25 HCC management protocol, and which has already been discussed. So my first question is to Dr. Shetty from the gastro side, from the gastro point of view. Like, what is the load of HCC that he sees on an average, and how has been the trend over the last 5 years? If you can share.
No, all the memories of T Raja, my mind is bringing in front of me.
Dr. Sethi, right?
Dr. Shetty, Ashish Shetty, or even if he's not around, if
Dr. Ajay is there.
Dr. Manas can take this question.
I think first let me just invite the panelists. Dr. Bhavin Shah is there. Dr. Richard is already with us. Dr. Manas, are you there?
Yes.
So please keep your yes. We
Yeah,
can
sure.
so that we know that you are there. Dr. Ashish Sethi, are you there? Dr. Ajay was there. Dr. Ajay, are you there? I could see him till.
Yeah, I saw here Dr. Ajay.
Yeah,
So,
and Dr. Ajay is there. Dr. Chawda is also there. So Dr.
Yeah,
Hitesh Chawda is also there, and Dr. Mithun is also there.
You are also there. Dr. Bhavin is also there. Yeah.
Yeah, so everybody is here except for Dr. Sethi. I can see everybody. Now maybe you can ask your.
Yeah, so Manas, if you can take these questions, like what has been the trend from in an HCC over the last 4 years, and how many on an average cases that you see?
So I would like to say that nowadays we see more of an advanced disease, more in the patient with vascular invasion, and more patients coming from etiology like a non-viral etiology as compared to the viral etiology. So these are the main patients we see.
So, Dr. Feen, is it similarly that the viral HCCs are going down, and similar presentations for you as well for
Yeah, for sure. For sure. I mean, look, hepatitis C has been cured, right? But patients still remain at risk. It decreases the risk of liver cancer. But, in the US, the main driver over the past decades historically has been Hep C, but that's peaked and probably coming down as the drugs are more effective. And, I'm in Los Angeles on the Pacific Rim, so we do see a fair amount of hepatitis B as compared to other parts of the country because we do have a large Asian population. But without a doubt, the obesity epidemic, and insulin resistance, all of that is playing into this very rapid rise in fatty liver disease and MASLD-related HCC. It's a big problem.
Yeah. So by the time the muscle comes in, they are not on a regular follow-up. So unlike viral hepatitis, so they tend to be at a later stage. So question to Dr. Ajay Choksi. So, what would be your is presentation etiology has already been discussed, but socio-economic factors affecting treatment decisions. So do you think that this all matters to you and your patients when they come to you for treatment? Or is it just the ideal treatment-based, guideline-based treatment? Dr. Ajay? If Dr. Manas, if you can take it, the question. Ajay is also not around. So this is for the gastros and the hepatologists who usually manage the chronic liver disease.
So the main hindrance in the treatment part, as far as the socio-economic factor is concerned, is the one of the factor is that as the MSLD is increasing, the patient have higher comorbidities also, as we discussed, and the treatment cost. These two are the main things as far as the socioeconomic factor is concerned.
So for Dr. Feen in the US, would insurance drive the treatment decision between the TKIs and the immuno, or would you have the choice to go ahead and get the immuno for the patient's benefit directly?
Yeah, I can't remember the last time I had a patient who could not get an ICI doublet because of financial restrictions. Things are broadly reimbursed here. There is a social program, Medicare, Medi-Cal, programs that do reimburse for these agents, and usually there's minimal or marginal copay. I know in India it's different, but we do spend a lot of money on healthcare here in the U.S., and a lot of that is, on reimbursement.
The patient gets the benefit. Over here, the problem is at the cost. Most of the patient, in spite of needing the therapy, they don't afford it. It's an out-of-pocket expense, and that's why they end up getting alternative therapies.
Yeah, no, I understand.
Coming to Dr. Chowda, there was some discussion about TACE eligible patients having response to systemic therapy and ICI. So would you consider adding ICI to a TACE therapy or combination, or just an initial ICI combination in the patient who are TACE eligible?
So usually the approach is, it's individualized approach depending on the tumor, the background and everything. But usually we would like to combine with the TACE and then followed by the immunotherapy. That's what we usually do.
So TACE followed by probably 2 weeks down the line, you would offer them immunotherapy if the cost is not a concern.
Yes.
So Dr. Feen, would it be similar? Would you offer a combination therapy if in a TACE eligible patient undergoes a TACE? And would he be put on post-TACE, any kind of an immunotherapy or even a TKI post-TACE?
Yeah, that's a good question, because we now have a lot of phase 3 data that, tells us that adding these improved PFS, not necessarily OS. With that being in mind, it's very hard to show in a clinical study where survival is 3 years or longer that you can improve OS. Just from a clinical trial design standpoint, it becomes very challenging because there's so many treatments post-progression. And that is why PFS has been the endpoint for these combination studies. With that being said, once you put someone on systemic treatment, it's kind of an indefinite course, right? Unless you can, as you're referring to here, downstage them, right? So there are patients, I think, given that the M-resist response rates are over 80%, right? When we combine things, I think the potential role for this group is to get patients to either resection or transplant, to downstage them, right? I think the combination becomes a very powerful way to downstage patients. If patients are never going to be a candidate for something curative, I'm more likely to start with like either TACE as definitive or TARE, radioembolization is used a lot here. Use that definitively and at progression start, something like atezo-bev, or start with atezo-bev and depending on their response, then refer them for tear, resection as consolidation, right? You have patients who have larger tumors in the liver who might not be good candidates for a catheter-based approach like LRT. And these patients, many of them will have dramatic or very strong responses to something like atezo-bev, and then, do something like tear or resection or ablation, transplant to get them off systemic treatment, right? And maybe they are cured, or as Dr. Kudo has talked about, just a disease-free interval, or treatment-free interval. So that's where I see a good role for this.
But not upfront combination as of now.
Not for everybody. Not for everybody.
Yeah. So there is some modification by the Indian National Association of Study of Liver Disease, and they do recognize that there is an emerging role for combination, but they have still said that we need to wait for more trials before actually recommending that. Now, coming to, as you have already discussed, a lot of trials, and the BCLC 2025 have now incorporated 2 more regimens as a first-line therapy, which were discussed today, that they are now considered to be a first-line therapy. So my question to all oncos guru, Dr. Abhishek, you can take this first, that, with more and more options available as a first-line therapy, so what makes you choose one therapy over another therapy, with all being the first-line therapy and the cost if being similar or slightly different?
So as of today, as I already said, Dr. Finn elaborated quite well as to that is why he was stressing on the fact that bleeding is not a challenge. Possibly one of the reasons for using a double IO was patients who had a risk of bleeding. Also, viral versus non-viral, there is a lot of debate about that, but possibly most of these regimes and the atezo-bev, we have had the longest experience. So I'm very comfortable if we have an HCC on using atezo-bev as a preference. There is always a question that somebody is not able to tolerate bev, which is quite rare to happen. You could use a double IO combination, but any of these immuno combinations I'd be happy to use. Preference would be into atezo-bev just because of the experience that we had with it since the last several years. Maybe Dr. Bhavin and Mithun can add something.
Yeah. So any difference of opinion from the colleagues, Dr. Bhavin, Dr. Mithun, or even Dr. Chirag Desai, if is alive?
So what Abhishek had mentioned, that if before starting the treatment, we see a lot of parameters, that whether what is the patient is fit for immunotherapy or not, or whether the patient can afford the treatment or not, or associated comorbidities which can allow us to treat that patients with the doublet treatment, or we can use a TKI. Now, as we all know, we have burned our fingers with TKI. The tolerance of sorafenib was worse. Lenvatinib, I don't think most of the patients can tolerate beyond 8 milligram dose. And when we use atezolizumab plus bevacizumab, the tolerance is excellent. We have a fear of bleeding because we are using bevacizumab, and these patients have already varices there. So, but before starting any VEGF inhibitors, we usually do endoscopy, and if there is any varices, we try to bind them so that the chance of bleeding can be minimized. So at present, as TREM is not available in India, atezolizumab plus bevacizumab is the treatment of choice for us.
So when you're selecting like a therapy, when we do not have a head-on-head, so Sora and Lenva, I'm not considering as of now, but between an doublet as well as atezo-bev. So would this curve separation, which Dr. Finn, categorically discussed, that the earlier curve separation and the hazard ratio and overall response rate, would that make a decision or the durability? Dr.
I think yes.
Yeah.
I think the response rate also matters, so that makes a difference. And the response rate and the early separation of curve, because this HCC patients are symptomatic, so that scores. That is one of the reason why we are more comfortable and used to using this bevacizumab plus Tecentriq combination. I do agree on that.
So early separation is something that would affect your treatment decision.
Yes, yes, yes.
So this is what Dr. Finn described about the earlier separation of the curve for atezolizumab. We'll not go into the data about all those comparison which has been categorically described. But coming to I think that the myth has been broken about the varices. But here the question is about, it was mentioned that if there are varices, we would like to ban it. So the question here is to the gastroenterologist and the hepatologist. So what would be your level of, treating those patients? If patient is likely to be on atezolizumab and you are advised to scope as a prior, which is a prerequisite. So what would be your level of treatment decision on banding? Manas, Dr. Shetty, or Dr. Ajay, if you are
larger varices, I would prefer banding them if before subjecting to them any of these immune checkpoint inhibitors, and before starting bevacizumab. I think banding larger varices, the smaller varices with no high risk signs, then we can leave them like a grade 1 varix.
Any difference of opinion, Manas?
No, similarly, varices needing treatment, grade 1 varices only beta blockers, grade 1 2, grade 3 varices banding plus secondary plus beta blockers.
Yeah, so this is a gastroenterologist perspective. When we are being referred and there are grade 1 2 varix, small varix which are mentioned, so the question always comes up, why didn't you ban them? But there's no indication to ban them. They are not likely to bleed unless there is a red cherry spot or a high risk feature, and giving them an additional beta blocker like a routine portal hypertension management does the work. So it shouldn't be banded, and I don't think that we should be even treating them. Grade 3 4 varix, most of the people, or if requiring bevacizumab, would be banding. So the question here is again that, in the hepatology guidelines, we don't need to even scope patients who have a liver stiffness measurement less than 20 and a platelet of more than 150. So now MASL taking over and a lot of non-cirrhotic HCCs coming up. So if this is a scenario, should we be scoping?
So I would differ from the Bavino guideline is for a compensated advanced chronic liver disease. So they do not mention HCC. So whenever we are suspecting HCC, the varices or a portal hypertension behaves differently as compared to the routine liver disease.
So yes, so there would be a necessity for scope for all patients. So this has already been discussed, that the types of bleeding, but few more slides, that what are the likely risk factors for development of bleeding is higher BMI and higher ALB score. ALB score is about albumin and bilirubin. So lower albumin and higher bilirubin, they are more likely to bleed, and low platelet count, involvement of VP4 main portal vein, previous history of GI bleeding, or the people who are likely to require treatment for varices were significant risk factors for variceal bleed in patient receiving atezolizumab. But I think that myth has already been broken, that if there are varices, we shouldn't be giving it. And there's one trial ongoing, which is looking at actually, whether there is a need for eradication or not. So what they are designing is they are banding, and within 2 weeks of banding, they are starting the atezolizumab. They are not looking for a repeat scopy, but only after 3 doses of atezolizumab, they are doing a repeat scopy. And if they do require banding, again band, and then 2 weeks interval, and to start atezolizumab. So that trial is going to is an ongoing trial. Probably will come to know what is the benefit of scoping and giving prophylactic band ligations. There, if you need to stop bevacizumab in the patients after starting, if developing variceal bleeding, there is data that you don't need to that outcome is not affected, and you can give only atezo-bev. So again, coming to the etiology, I think that was about the MASLT. It has been discussed, but I will still ask the onco opinion whether if there's a patient referred to you for an HCC, would you be keen to get a workup done and look for an etiology, and would etiology make any difference? So Dr. Mithin or Dr. Abhishek, if you can take this.
No, at present, the knowing of etiology helps in the first line treatment will remain the same. I think but it helps in deciding whether you need antivirals for Hep C. Otherwise, my first line treatment will remain the same.
Dr. Abhishek, would you have anything like, would you refer this patient to get an etiological workup if there is an HCC in a patient?
So would always like to have an etiological workup, but as he already alluded to, the treatment would not change. At the most, adding a treatment for the etiology would help the overall outcome of the patient.
I think we never see a de novo patient of HCC in our clinical practice. Most of them are referred by a GI physician or a GI surgeon. So, but then whenever we start treatment, we try to find out the cause for the HCC. So without knowing the cause, I think it is difficult to treat. And if they are, if the patient has some viral etiology, then the antiviral can be added.
Also, so I was going to ask Dr. Richard Finn. So you see some of the most sick patients in India for HCC. So I think finding the etiology and treating that definitely helps in the overall well-being of the patient, because you can't just keep giving a atezo without even looking at what is going on in that patient.
Well, I think and I'm going to follow up on that point. Looking at what's going on with the patient, and it's not just a matter of looking at the report. It's actually looking at the scan and assessing tumor burden, because some of these patients will be decompensated because of their tumor burden, right? And you need to look at these patients, right? And your GI and hepatology colleagues can comment as well. But there are patients who are pretty well compensated, doing their thing, and then they decompensate, they get imaged, and they have a large tumor burden. And these are the patients who probably benefit the most from systemic treatment, even though they're Child-Pugh B or C even, that if they have a response, they will get better. That's different than the patient who's had cirrhosis and ascites and encephalopathy and then develops liver cancer. And, that patient's more likely going to die with cancer and end-stage liver disease. But there's a number of patients who I have seen, it's remarkable. And I'll give an analogy for our other oncology colleagues. There are patients who have a big tumor burden, and if they respond, they get better. And I had a case to that point, but I had so much to talk about, I didn't have time. But, in oncology, for example, if we have a woman with breast cancer that's metastatic to the liver and has a high bilirubin and ascites, but has never been treated for her breast cancer, we will treat her because if she responds, she gets better. And I don't think that's any different now for liver cancer. Even though they might have cirrhosis and having a tumor there decompensates them faster, if they have a response, they will get better. And the best chance of a response, I would argue, is with atezo-bev. And I think the safety, because we don't have the high incidence of hepatic immune-related events, is probably favorable there too. So, just because not every decompensated patient is the same.
So Dr. Finn, as you mentioned the data up to CTP-B8, you would attempt to tackle the tumor burden and get the disease stabilized. Up to that level, would you be keen to start?
I'll tell you what, I don't know that I actually calculate, someone who's sick or not, right? And regardless of their Child-Pugh, I mean, if someone can come to the office and make it to the office, and I think that there's a potential for benefit because of their tumor burden, I will have that discussion with them. And again, if they have an albumin of 1 and they're chronically ill, I'm not as excited. That's a hospice case. But for the patient who is functional but has, physiology, high bilirubin, ascites, that patient, I might say, if I made your tumor disappear, you would be back to where you were before. And I think they deserve a chance. Look, this regimen is once every 3 weeks, right? So in many ways, what do they have to lose, right? If you give it, often the responses are fast. So, you give them a Tezobev and you're either going to get better or you're not, and that is how I have this discussion. Because I don't think patients have anything to lose as long as I'm convinced there's a reasonable chance that they will get better if they respond. There's many patients, who we say, if I snap my fingers and your tumor disappeared, you'd be no different. And that's not the patient to do this for, right? It's the patient who I think whose their tumor burden is so cumbersome that it's causing their physiology or contributing significantly to it.
Yeah, coming back to the etiological aspect, do we actually get ANA tested for all these patients before we start?
Dr. Pathik, just 1 second. We have been joined by Dr. Chirag Desai, sir, and I think he would like to make some point on the previous question. So over to you, sir.
Yeah, so thank you, Malvika, and thank you, Pathik. So my question in a part was answered by Dr. Finn in his comment. So I lowered my hand again. But in general, patients with chronic liver disease are going to have the worsening of their condition. And Abhishek just made a comment that in India we will get the most symptomatic patient. But I think that is true for patient with chronic liver disease and with hepatocellular carcinoma world over. I mean, India or US is no different to that extent. And Dr. Finn rightly said that if the patient walks down to my clinic, I will be treating irrespective of whatever uh, uh, Child-Pugh score the patient might be having. And whatever chance of benefit the patient might be having, I will try to explore that chance. But if the patient comes in a wheelchair or patient comes in a stretcher, I think I will think twice before treating that patient.
So it's performance status and the eyeball test that we feel that we might be, rather than looking and
Absolutely.
sticking to the numbers.
The eyeball test.
Yep.
Eyeball
Yep.
test. It's something that we all would be
Correct.
practicing as a clinician.
Global term.
Yeah. So coming back to the clinical etiology, do we actually get ANA tested for our patients before starting immunotherapy? So does anybody get an ANA tested?
ANA, like anti-nuclear antibodies?
Anti-nuclear antibody.
No.
So nobody gets an anti-nuclear antibody
No,
before?
it's not. It doesn't predict anything. If someone has a history of lupus, or it's again more of the clinical decision making than the laboratory analysis. But I don't think any of us do that.
So even if it's MASLD or now Hep B or Hep C, it won't affect the treatment decisions for us as well.
Yes.
Yeah. So there is just some data published from Asia Pacific saying that viral versus MASLD versus non-viral, non-MASLD, the ORR is around 23 to 25%, PFS similar, and overall survival quite similar.
There you go.
Yeah, so even if it's whatever etiology, this is again what Dr. Finn presented, and on a post-hoc analysis also it showed similar response. So coming to the personal experience, on a real-world experience, Dr. Abhishek, would you be able to tell about your personal experience, real-world experience with Atezolizumab? So how has your been response?
I think the responses have been few and intermediate. So I wouldn't say 20% have been long-term responders. Less than 10% have been long-term responders to a Atezolizumab combination, not reflecting the trial data. But then there are one in a 10, I would say, not 1 in a 5 who have been long-term responders.
So when you say long-term responders,
Or have actually responded to the treatment beyond 6-8 months.
So that is a complete response you are talking about, or a partial stable disease?
Partial response or some response to the treatment.
Okay. Dr. Chirag Desai, Dr. Mithun, would you...
See, I agree the response rates are not very high, but I wanted to add that few patients who have got CR, and I would like to Dr. Finn's comment also. So if the patient has got a complete remission and the patient is on atezo-bev for almost 1.5 to 2 years, what would be the plan on how long to continue, or can we discontinue and re-challenge after some time?
Yeah, thank you very much. I mean, this is a real problem. It's a good problem to have. You know, patients who
I
have
know.
dramatic responses, and when do you stop? And I'll tell you, I don't think it's written in stone, but it becomes a conversation with the patient. And I have a few patients who I've recently stopped.
Yes.
That I mean, and these are people who should be dead by any prior, you know, assessment based on where they started. So, you know, I think at the beginning someone mentioned about lymphoma. I mean, I tell people it's like being a lymphoma doctor now with this, because we see these responses and patients do so well. So there's no set time. You know, I talk to the melanoma people about this a lot historically, because they had the drugs longer. Now we have them just for many years. You know, like if you look at some of the Pembro studies, they stopped at like 2 years automatically.
Yes.
Yeah.
Mhm.
These studies have been till progression. I have patients who, you know, at around 2 to 3 years, they start saying, you know, do I need to come in and this and that? Some of them have proteinuria, and now they're only on atezo. So I have stopped on several patients. Some I have continued because they're comfortable. You know, what we don't know is if you stop, they recur, can you re-challenge them and get that response again? There's no good sense of that. For some of the ones I stop who might have like a strong PR and not a CR, I'll do a TACE or a tear or an ablation just to consolidate it and then stop. Or do that and then a few more months and stop. So I have stopped on a few patients so far.
Thank you.
Dr. Richard, many times it happens that the patient has very small amount of disease with vascular invasion, and you do a tear, and if you give a immunotherapy, Tecentriq plus bevacizumab, and with vascular invasion disappear, we can consider them for transplant also. So
Yes.
Yeah.
So how long we have to stop the immunotherapy before we consider for transplant?
Okay, yeah, that's a good question. And then I see a question in the chat that I'm going to answer real quick. But, you know, this has been evolving. There's been some nice multi-center collaborative studies. Dr. Tabrizi from Mount Sinai put together a nice manuscript not that long ago. You know, ideally you stop like 3 months before, but you never know when someone's going to get a transplant unless it's liver directed, you know, liver donor, live donor. But we've had several cases in the literature now that are done within a month or even on IO. And there's a higher risk of rejection, but I think people are starting to think it's pretty safe. You know, people have used some different protocols for maybe higher immunosuppression up front, you know, shortly after transplant. There is an increased risk of rejection, but, you know, we've done a few at UCLA and we haven't had many problems. You know, patients who decompensated very fast while on the list. We weren't expecting them to get a liver and they've done fine. So it's a real issue to be aware of. If you can control it, you know, they say 2 to 3 months. If you can't, you just do your best. Right. And
any bridge therapy between the transplant and
I mean, I don't know if, you know, I would argue if someone's going to blast off after stopping atezo-bev and they can't wait 2 months, that patient's probably not a good transplant candidate, you know? You know, they should be able to wait a little bit and show stability. You know, I had a patient recently in the US who we wanted to transplant and get exception points. And they were on IO and they said, well, stop the IO first and we want to see how they do, just to see if the tumor is going to explode. So, you know, I don't know that they need bridging. If you're so worried, I think probably you could do lenvatinib safely as a bridge. Someone asked about single agent atezo after stop. Yes, for sure. In the study, a number of patients had to stop bevacizumab because of toxicity, hypertension or bleeding or proteinuria that couldn't be controlled, and they continued on single agent atezo, and that all contributed to the outcome. And we actually had a manuscript. I think Dr. Kudo was the first author about skipping Bev, and it shows that you get similar outcomes when it's stopped for protocol-mediated toxicity.
So you stop for 3 months and then transplant and keep patient on atezo.
I think if you have the ability to control that, right? Stop for 3 months. The question was not about transplant specifically. I don't think.
I think Dr. Bhavin is talking about the patient who is supposed to have transplant in the living donor scenario.
In a living donor.
Yeah.
So living donor, yeah, I don't know. I bet you could stop for 6 weeks and probably do fine. Longer the better. But I think, that 6 to 12 week range is probably ideal.
We had this discussion during our Liver Transplant Society meeting, and a couple of transplants have been done in India, and they have waited for 12 weeks to just make sure that there is no recurrence and the disease is stable. And there is a washout period for atezo. So at 12 weeks, they have transplanted, and if they have done it before, there is quite high incidence of rejection requiring prolonged steroids and even plasma exchange. And for the fear of recurrence, there's no logic behind it, but a couple of centers do start lenvatinib post-transplant and continue for 6 months post-transplant, just assuming that it would take care of any circulating tumor cells.
So any guidelines to take any?
This is just expert opinion, which we had discussed during the liver transplant meeting in India, and that what they have transplanted people after HCC and downstaging, because in India, majority of them are going to be living donor liver transplant. So we have an elective option to decide the date and the time for the transplant, and we usually tend to wait for 12 weeks.
So they're off treatment, basically.
Off atezolizumab for 12 weeks, and then get a PET done to document there's nothing there, and then transplant. And once the patient is stable post-transplant on a stable immunosuppression, 7-10 days, then consider TKIs to continue for a few weeks.
Correct. Recently, we have a paper from Gut BMJ who had predicted the rejection rate in the post-transplant setting post-atezolizumab. So that is also one of the predictors. 12 weeks, less than 12 weeks was one of the predictors.
Yeah.
No, but what is the standard, Dr. Finn? What would be the standard treatment post-transplant in such a patient?
I think just observation. We have a large transplant center here, and I often see these patients at least for a one-time consult. Unless someone has, even in the post-resection, the data is very poor on adjuvant treatment, let alone, transplant, right? There was data at ASCO about neoadjuvant or ESMO, neoadjuvant and neoadjuvant adjuvant with surgery in between with atezo-bev that looked very promising from China. But right now, we don't have data post-resection. So I don't offer patients post-transplant adjuvant treatment, certainly not IO. But really, I'm not doing anything for patients unless they develop, recurrence. And at that time, it depends on the recurrence. The time from transplant, is it oligometastatic? I saw a guy yesterday who recurred with like some retroperitoneal lymph nodes post-transplant, like 2 years after we radiated them, and he hasn't recurred for another 2 years. So, it's not all the same. Everybody's very different,
Great.
I think I'm going to have to go. Just
a couple of slides and we are going to finish it off. Just a few more minutes. So there's some real world study from Taiwan showing 60 months overall survival for 19.6 for atezolizumab as well. And those who did respond in the subgroup analysis showed a 47% 60-month overall survival rate. So as said, that a lot of studies had excluded VP4 patients, and atezolizumab did include patients, although slightly inferior, but that is similar overall better response to other therapies. Skipping bevacizumab, I think that has already been discussed, that we can skip patients, and even after A plus B, they do remain sensitive for a second-line therapy. So as a last few comments before Dr. Finn, for us to know, using much more atezolizumab from your experience, that we need to keep in mind.
Look, I'm obviously conflicted academically. I'm a big fan of the regimen, and that also is not just my conflict, but from using it over 5 years now. We're just seeing amazing responses, right? That's not to say you don't see responses with the other regimens, but I think the likelihood of getting a response is higher with atezo-bev. And I think the safety to me is reassuring as far as these autoimmune events. Some patients, they have an autoimmune event in the liver, need steroids, and that pushes them over. And so for me, the first question is, can they get BEV? And then can they get an ICI? A little different than the ESMO approach.
Thank you. I'll just close. Will not go into the detail about the newer one. Thank you for your time, and thank you for guiding us. So
Thank you. Thank you, everybody.
Okay, everybody. Happy New Year. Stay
Happy New
healthy.
Year.
Happy
Happy New Year.
holidays.
Thank
Hope
you.
to see
Thank
you
you.
all in
Thank you,
person.
Thank you,
Dr. Finn.
Professor
Thank
Finn.
you,
Thank
sir.
you so
For your
much.
time.
Thank you.
It was a pleasure having you. Thank you.
That I
Thank
think we
you.
can
Care.
thank all the participants and probably end the discussion. It has been 9:30 now. Unless until somebody has a question again.
Fine, fine. Good night.
Good
Good
night.
night, good night, good night, good night.
Good night.
Night. Night.
Bye bye.